Hello, and welcome back to the Group Practice Podcast. I'm Neal Goldstein, your host. Today, I'm going to talk more specifically about group practice and the group practice definition that is statutory and also is in the federal regulations. And the term itself is in the federal Stark law. So I'm going to give a little bit of a background on Stark, and then I'm actually going to have another episode which gives you, the listener, a high-level overview of the Stark law. But the Stark law it's the physician self-referral law, and it is a prohibition. It prohibits a physician from making a referral for a designated health service for a Medicare or Medicaid patient to an entity with which the physician has a financial relationship, unless an exception applies and the entity itself is prohibited from billing. So that's the Stark law that bans a doctor from making referrals for a designated health service, and there's about 10 of those. It prohibits the physician or the physician group from making that referral unless an exception applies. And the exception that is commonly used, by far and away the most common exception used by the physician group, is what they call the in-office ancillary services exception. And the spirit of that law is that as long as you're providing the designated health services in your office, if it's part of your medical group, then we will allow you to own that designated health service, provided you meet certain requirements. And the in-office ancillary service exception itself has 4 general requirements, but 2 of which relate to group practice. The 2 components, or the 2 most applicable requirements under Stark that utilize group practice, are the supervision requirements and the centralized building requirement, and also the same building requirement. By being a group practice, you avail yourself of the ability to meet the supervision and the building requirements. And there's other areas within Stark, but to put it another way, those 2 components, those 2 requirements, you essentially, as a group, would not be able to meet unless you met the definition, that is to say, the requirements of group practice. So as far as what a group practice is, I'd like to start off with just a general comment that CMS has that's taken straight from the preambles to the regulations. And what CMS says is, we believe that Congress intended a true group practice to consist of physicians whose practices are fully integrated medically and economically. In short, the physicians practice medicine together in a single group, not separately, and their financial prospects are interdependent. So this is CMS saying, this is what how we interpret the statute itself and what Congress meant by saying what a group practice is. This is like the general overview, the theme, if you will. Now, as far as the group practice definition goes, there's several requirements, but there's 2 key requirements that I'll talk about today. One is the unified business requirement, and the second is the single legal entity requirement. We'll start with unified business, and we'll start with the preamble, the commentary that CMS, actually, we'll start with the regulation text, and then we'll go to the commentary. The text of the regulations as it pertains to what a unified business is, it says that a group practice is a unified business having at least, not just, but at least the following features. Centralized decision-making by a body representative of the group practice that maintains effective control over the group's assets and liabilities, including but not limited to budgets, compensation, and salaries, and consolidated billing, accounting, and financial reporting. So those are there's many other, requirements, but as it pertains to unified business, it's just those two. But those two elements, those two requirements are very important, and they're very broad. What they're looking for is a central board of directors or a board of managers that has real fiscal authority over the debits and credits, the assets, liabilities, cash flow, whatever, over the practice. So not just a bunch of practices where they're siloed off and are insulated from each other. No, it's one practice that has one centralized board of directors, board of managers that has the authority, the power, the control over the financial matters. And the second requirement is all of that to be consolidated as it pertains to financial reporting, consolidated billing, and accounting. So that's the text. And the commentary I find to be enlightening. The commentary said, we designed the rule to preclude group practice status for loose confederations of physicians that are group practices in name, but not operation. So they really want to see unity. They really want to see something that's integrated. Next, we'll turn to the single legal entity. The regulation text there is the group practice must consist of a single legal entity operating primarily for the purpose of being a physician group practice. Then it goes on to say, for purposes of the subpart, a single legal entity, and they basically reiterate what they've said earlier on unified business. A single legal entity does not include informal affiliations of physicians formed substantially to share profits from referrals. So that's the text. And then the commentary piece says it again, but goes in a step further by saying, no loose confederation, you can't have as your substantial purpose to share profit from referrals. And then they go on to say, sometimes referred to as a group practice without walls. When I first started practicing in this area in the 1990s, there were many groups that were not just set up as group practice without walls, but they promoted themselves as that, as a way to bring in other physicians, other groups, because physicians crave their autonomy and their independence. And so a group practice without walls would essentially mean that you can be your own group without having oversight by a central authority. And what CMS said in their commentary was that is not a group practice. So those are the regulation text, the relevant portion of the regulation text, and the commentary on it. And I will say, as I said in the premier episode, that I believe that complying with the group practice definition makes a lot of business sense. And not only does it mean you're complying and it allows you to comply with the in-office ancillary services exception, but it's a good structural tool. One of the things that I really pride myself on is the clients that I showed you in a slide in the premier and the clients that I have today, they've all been around for a long time. They've all weathered the storm and they've not broken apart. Some have been together 5, 10, 15, 20 years, IBJI 35 years. Some have sold to private equity, but still remain as a group within the private equity setting. And the reason for that is because of the structure. I like to think of myself as a structural engineer. I put a lot of emphasis, a lot of thought, a lot of time into structuring groups. And if you have a strong structure, you have a strong business. If you have a weak structure, you may have a profitable business, but not one that is set up for the long term. The final thing that I'll talk about in that regard is I'm going to take a slide that my brother Wayne uses when he gives talks about doctors' groups. And it's all about one of the most important things for independent medicine, for private practice. It's sticking together. And so he quotes the poem by Kipling, The Law of the Jungle, which you can read. But he emphasizes the last piece of it, which is for, and this is his picture too that he uses, that the strength of the pack is the wolf, and the strength of the wolf is the pack. What that means is sticking together. What does sticking together mean? It means being integrated. It means not just having an informal affiliation, but to truly be integrated, committed, contractually bound to one another. That is a very powerful tool to have for your medical group, because it will not only allow you to weather the storms of the competition, whether that be hospitals or other potential competitors who are looking to disband your group. It's a very good model to weather that storm, to execute on some great business strategies that you otherwise would not be able to enforce because you otherwise have a loose affiliation. But it's also a good model in terms of advocacy. What's interesting is you look at the American Hospital Association, the hospitals. American Hospital Association is the primary lobbying organization for hospitals, and they're very effective because they represent the major hospitals in this country. That perhaps used to be the case with the American Medical Association, but as medicine has become more specialized and subspecialized, the subspecialty or the specialty groups themselves have grown, and they themselves do advocacy for their particular specialty. But the advocacy for the entire physician organization, from my view, has gotten weakened over the years. And the insurance companies are exploiting that. The hospitals are exploiting it. And so how do you counter it? You counter it by remaining unified in whatever way you can. I'm not saying that you form a physicians lobbying organization. I'm not saying that at all. But to the extent there's advocacy, and to the extent all physicians, specialty, primary, all doctors sticking together, that is a great model for success, both for the profession, but specifically for the specialty, and in particular, which is the subject of this podcast, the group practice. I will be talking about the Stark Law in particular, and then we'll probably move on to business and structural topics. But this is why I named my podcast Group Practice, because not just of the legal aspects of it, but as far as the structure goes, I think it's an excellent structure. Thank you.